Hello guys, good evening everyone. Okay, so live is running. Guys, from today, we are also going to start a series of lectures on obstetrics and gynecology. Already we are doing a series of lecture on physiology. From now, we are also going to start a series of live classes on obstetrics and gynecology. Hope this series will be helpful for you. Now in this today's class, we are going to discuss about a very important topic which is called as endometriosis. So first we will be discussing endometriosis. After that, we are going to discuss the second topic which is polycystic ovarian syndrome. This topic of endometriosis is such an important topic that in every exam you can expect one MCQ from this topic. Having said that, can you tell me what exactly is endometriosis? Now everyone knows that endometrium is something present inside the uterine cavity. Endometrial lining is present inside the uterine cavity. Now what is endometriosis? In the name itself it's there, osis. Osis means pathology. There is some pathology happening to endometrium. Okay, now can you tell me what is endometriosis? The definition of endometriosis. I'm checking the comments guys. What is endometriosis? Anyone? Sachin, Kanwal, Tom, Harsha. Can anyone knows what is PCOS? Sorry, what is endometriosis? So you don't know. Okay, let me explain you. So the definition of endometriosis, see here, endometriosis is a disease in which tissue similar to the lining of uterus grows outside the uterine cavity. What does I mean by endometriosis is that endometrium which was supposed to be there in the uterine cavity, endometrium where it should be there, it should be present inside the uterus. But if endometrium, if it is growing outside the uterine cavity, then it is called as endometriosis. Okay, so endometriosis means endometrium which was supposed to be present inside the uterine cavity is now present where? Outside the uterine cavity. Might be on the surface of uterus, might be in the peritoneal cavity, it might be in some other tissue also. So this is the definition of endometriosis. An important point which you need to know is, sir, this endometriosis is going to be affected in which females, sir? Females of reproductive group or females who are post-reproductive group. Remember, very important point is usually this endometriosis is going to be seen in those females who are in reproductive age group, 25 to 35-year-old females. Now they will suffer with this condition called as endometriosis. Now you know the definition of endometriosis, but you will be getting a question, sir, why the hell does this female is getting endometriosis? Why the endometrium is growing outside the uterine cavity? Why? See, in this slide, I'm going to explain you why endometriosis happens. No one really knows why endometriosis happens, but there are certain theories, okay, which are explaining why endometriosis is happening in a female. Now, the first theory which I am going to discuss is called as the Samson's theory, which is also called as the regurgitation theory. Regurgitation theory. Now, what is the Samson's theory of regurgitation explains us, sir? Sir, it's very simple. Normally, try to understand like this. Imagine here is your uterus. Okay, here is your uterus. Okay, this is the uterus. Now, normally during menstruation, what will happen? Sir, the endometrial lining is going to get shed off and the endometrium is going to come out in the form of menses or menstrual blood. Now, see what Samson's theory of regurgitation explains us is, the endometrium is not only falling down, okay, not only coming out through vagina. So, during menstruation, some amount of endometrium is also going through the fallopian tubes and it is falling into the peritoneal cavity. Okay, the endometrium is regurgitating back into the peritoneal cavity, and this endometrium is falling onto the ovaries, it is falling into the pouch of Douglas. This endometrium can also spill anywhere into the peritoneal cavity. Okay, so what our Samson's theory is explaining is that, so endometrium is getting regurgitated back into the peritoneal cavity. Okay, now here in this image I have clearly shown you guys, see that this is the endometrial lining, right? This is the endometrial lining. See here the endometrium, where it is coming, it is coming and getting falling into the peritoneal cavity. Now that is the Samson's theory of regurgitation. Why endometrium is present in the peritoneal cavity? Because of the regurgitant endometrium. Okay, so the regurgitant endometrium due to retrograde menstruation. Now that retrograde endometrium is going to implant onto the peritoneal sites, and there it is growing, sir, unnecessarily, abnormally it is growing in the pelvic cavity. Now there is one more theory called as the benign metastasis theory. Now we all know metastasis means usually spreading. Okay, cancer, malignant cells, cancerous cells, they are going to spread from one area to other area via blood vessels and lymphatics. Okay, now in the same way, this benign metastasis theory is explaining us the endometrium somehow got access into the blood vessels. Endometrium, it is entering into the blood vessels, and this endometrium is getting into different parts of the female's body. It is getting deposited in the female body in lots of other places, and there it is growing. So this is called as a metastasis theory given by Halban. So what is metastasis theory is teaching us? See, the endometrium is spreading via blood vessels and lymphatics to the distant sites. Now this endometrium, it can spread into lungs or not? Yes sir, it can spread into the lungs, it can spread into the eyes, it can spread into the nose. Okay, it can spread into any part of the body, and it can grow and cause endometriosis in the female. Don't think like endometriosis can only happen in the pelvic cavity. No, endometriosis can happen anywhere in the body. Endometrium can get access into the blood vessels, and it can go into the distant parts of the body, and it can cause symptoms, endometriosis. Now what is this metaplastic theory is telling us? Now endometriosis is also explained by this one theory called as a metaplastic theory. Now what is metaplasia? Metaplasia means changing of one type of epithelium into other type of epithelium. We all know from the physiology and pathology also, metaplasia means changing of one epithelial cell type into the other type. Now this metaplastic theory, which was given by Mayer and Ivanov, is explaining us, sir, now tissue wherever, for example, now the tissue which is present in the peritoneal cavity, there is this one epithelial cell, sir. Now because of some reason, because of some mutations, the epithelium which is present in the peritoneal cavity, it is getting changing into the endometrium. Metaplasia is happening. So the epithelial cell type which is present in the peritoneum, it is undergoing modifications, it is undergoing metaplastic changes, and it is turning into endometrium. So from this, what we have studied, sir? So there are three important theories explaining why endometrium is present outside the uterine cavity. The first theory is Samson's theory of regurgitation. Regurgitant endometrium is there. Okay, regurgitant menstruation is happening. That's how endometrium is coming into the peritoneal cavity or the pelvic cavity. Second theory is metastasis theory. Endometrium is coming into different organs because of metastasis. Endometrium coming into the blood vessels, from there into different sides of the body. And the third theory is metaplastic theory, where the tissue, the epithelial cells in different parts of the body are undergoing mutations, and they are changing into endometrium. Okay, so these are the three important theories. Now here, the most widely accepted theory is what? The most widely accepted theory is Samson's theory of regurgitation. So Samson's theory of regurgitation is the most favored or widely accepted theory. Okay, but this theory has certain drawbacks. Now what are those drawbacks? We will discuss. But before that, I just want to talk a few more important points regarding this Samson's theory of regurgitation. Okay, see guys, important point is normal females, even in normal females, during their menstruation, some amount of endometrium will go back or spills back into the peritoneal cavity or the pelvic cavity. This is something very much true. See, even normal females, okay, 70 to 80% of the females, there is normal retrograde menstruation is going to happen. Normal retrograde menstruation is happening in almost all the females, 70 to 80% of the females. But the 70 to 80% of the females are going to suffer with endometriosis? No. Not all the females whoever are having the retrograde menstruation are not suffering with endometriosis. Then what is important? Retrograde menstruation is not important. Now the female should have to have certain important high risk factors. What are they? Sir, the important risk factors to develop endometriosis is low immune status. Okay, the first important point is low immune status. And second important risk factor is hyperestrogenic states. Now, let's imagine I'm a female. Okay, imagine I'm a female. Now, in most of the females, I have explained you, there is retrograde menstruation is happening, sir. Okay. Now, even retrograde menstruation is happening, but not every female with retrograde menstruation will develop the endometriosis. Now, to develop endometriosis, this female along with retrograde menstruation, her immune status should be low. She should be immunocompromised patient. Okay, she might be a diabetic. Okay, or she is having, she is taking steroids so that her immune status is low. So, less immune status or low immune status or immunocompromised patient along with hyperestrogenic states. I will give you examples of hyperestrogenic states. In her body, there is excessive amounts of estrogen is present. Now, this excessive amount of estrogen is going to stimulate the endometrium. Whatever the endometrium regurgitated back, now that endometrium is stimulated because of this hyperestrogenic states. Now, because she is having so much amount of estrogen, we all know estrogen is like a food. Estrogen is like a stimulant for the endometrium. So, endometrium is now growing. And low immune status. Now, in a normal female, whoever is having this retrograde menstruation, all that retrograded menstrual blood is going to be definitely going to be cleared by macrophages. But our female is immunocompromised female. In her body, the immune status is very less. So, whatever the endometrium which got regurgitated back, now it's not cleared by macrophages. Now that endometrium is going to implant onto the surrounding tissues because of the hyperestrogenic states, it is growing. Okay, so these are the reasons why endometriosis is happening. I have given you 3 theories. Now, let's see what are the limitations of Samson's theory. The limitations of Samson's theory. Now, Samson's theory fails to explain endometriosis in distant organs. Okay, endometriosis, I have said you, endometriosis, it can happen in the nose also, it can happen in the eyes also, endometrium growing in the eyes. Now, what Samson's theory is telling us? Samson's theory explains us endometrium is getting regurgitated back. If it is getting regurgitated back, endometriosis should have to happen only in the pelvic sites. Endometriosis should have to happen only in the pelvic sites because regurgitated endometrium is just falling in the pelvic area. So, according to Samson's theory, endometriosis should have to happen only in pelvic side. But in reality, endometriosis, it will happen in eyes, it will happen in nose, it will happen in lungs, it will happen in liver, it can happen anywhere. So, Samson's theory is failing in explaining why endometriosis is happening in the distant sites. And trust me, this endometriosis can also happen in those females who are premenarchal. Okay. So, endometriosis is also happening in premenarchal females. Premenarchal means a female who is 10 years of age. In her, menses has not started. If there is no menses, how come retrograde menstruation will happen? So, Samson's theory is failing here. Okay, endometriosis can also happen in premenarchal females who have not yet started the menstruation. So, how to explain this endometriosis in distant organs like lungs? How to explain endometriosis in premenarchal female? How means? We are having other theories. What are they? There is metaplastic theory is there. Metastatic theory is there. So, metaplastic theory and metastatic theories, now they are explaining why endometriosis happen in distant organs. Okay. Now, after this, let's discuss about some important MCQs which were asked in the exam. Endometriosis can occur anywhere in the body. Yes, true. It can occur in the abdominal wall, no doubt. It can occur in lungs, it can occur in pleura, eyes, brain, GIT, nose. It can occur everywhere. But what is the most common site, sir? What is the most common site? Think logically and tell me, guys. See, here is your uterus. Here is your uterus to which fallopian tubes are attached like this. I am just drawing you in a simple way. Now, here are your ovaries. Okay, here are the ovaries present. Now, what is happening? The most widely accepted theory is retrograde menstruation theory. Now endometrium is getting regurgitated back and it is getting into the pelvic cavity. Now when it is falling, it's going to fall on which side? Most commonly, ovaries are very nearby. So endometriosis, now it will mostly commonly going to happen on the ovaries. So the most common site of endometriosis is ovaries. Now after ovaries, what is the second most common site? Now all this regurgitated endometrium, it's nothing but blood, right? It have to gravitate down, it have to come and collect in an area. So wherever there is bleeding in your abdomen or wherever there is fluid accumulation in your abdomen, where it will come? All the fluid will come down and gravitate in an area called as pouch of Douglas. So the second most common site for endometriosis is pouch of Douglas. So what does I mean by? Now endometrium is most commonly growing on ovary. Second most commonly growing on pouch of Douglas or cul-de-sac. So important point is the most common site is being ovary and the second most common site is pouch of Douglas, which is also called as cul-de-sac. Now what is the most common site for extrapelvic endometriosis? Not in the pelvis. Other than pelvis, what is the next most common site? Next most common site is sigmoid colon. Okay, sigmoid colon is the most common site for extrapelvic endometriosis and the least common site. I have already explained you. Endometriosis, it can happen anywhere in the body, but the least chances of endometriosis is seen in brain cell. Now here what I am showing you is, see, this is the ovary where the endometriosis has happened. Now whenever a ovary is affected with this endometriosis, whenever this endometrium, the endometrial implants are falling onto the endometrium is falling onto the ovary, it's getting implanted over there, it is going into the ovary and it will form a cyst, sir. It will form a cyst inside the ovary, which is called as endometrioma. So what is endometrioma? Endometrioma is nothing but the ovary which is affected with endometriosis. Now even in ultrasonography, you can see this endometrioma. So these are some important points which you need to know. Guys, here what I am showing you, this image based question is scar endometriosis. What does I mean by scar endometriosis? Wherever you have a scar, hysterectomy scar or the C-section scar, okay, or the myomectomy scar. Myomectomy, when you will do myomectomy, whenever a female is suffering with a condition called as uterine fibroids. Okay, the female is suffering with a condition called as uterine fibroids. We will discuss what is uterine fibroids in the subsequent lectures. But the treatment of uterine fibroids is what? Myomectomy. So whenever myomectomy is done, definitely there will be a scar, right? Definitely there will be a scar. Now on that scar site, this endometrium is getting implanted and it is growing. So what is scar endometriosis means? On the scar sites, fibrous tissue sites, the endometrium is going there and it is proliferating there, causing endometriosis. So hysterectomy scar, C-section scar, okay, myomectomy scar and episiotomy scar. Episiotomy is done during labor. Okay, so all in the scar sites, endometrium is coming, it is growing there and causing endometriosis. Okay, now after this, let's talk about a very important condition which is called as vicarious menstruation. What is this vicarious menstruation, sir? Okay, what is this vicarious menstruation? Guys, this is very interesting. Sir, try to understand like this. There was this one female. Now she is coming to you. Think that you are the gynecologist. Okay, you are the gynecologist. Now she is coming to you and she is saying her complaint. Now her complaint is, doctor, every month I am getting my menses. No doubt. She is getting the menses. Now that menses are very, very painful menses. Very painful menses. Why menses is painful, we will discuss, don't worry. But some important aspect is, sir, with every menses, now she is bleeding from her eyes. Now during menses, bleeding is happening through her vagina, it's okay. Endometrium is coming out of her vagina, it's okay. But here this female is saying, during her menses, at the same time she is bleeding through her eyes or bleeding through her nose. Why it is happening? Why she is bleeding through her eyes and bleeding through her nose? It's because, see, during her menstrual time, now she is actually suffering with endometriosis. Now what is endometriosis? Growing of endometrium outside the uterine cavity. Now in this particular female, do you know where endometriosis is happening? Endometriosis is happening in her eyes. Just like normal endometrium which sheds every 27 days, okay, which sheds out every month. Now the endometrium which is growing in her orbit, also shedding and it is coming out. So she is menstruating through her eyes every month at the same period whenever she is menstruating through her vagina. Okay, at the same time she is menstruating through her eyes. She might also menstruate through her nose. So this is called as vicarious menstruation. So this is the cyclical bleeding through nose and lungs, like through her nose because endometrium is growing in her lungs. Okay, or through the eyes because the endometrium is growing in her orbit. So this is called as cyclical bleeding, which is coinciding at the exact time of her normal menstrual cycle. This is vicarious menstruation. Now after this, let's talk about risk factors, sir. Risk factors of endometriosis. Now see, try to understand like this. All the risk factors, whatever I have mentioned here, all these risk factors, some way or the other, related to more number of menstrual cycles. Now in all these risk factors, one thing is common. Now she will be having more number of menstrual cycles. Now what does I mean by more number of menstrual cycles? See, the more the number of menstrual cycles, more possibility of retrograde menstruation. The more the number of menstrual cycle, more chances of retrograde menstruation. So more the retrograde menstruation, more chances of endometriosis. Okay, don't worry, we will discuss one by one. First risk factor is early menarche. Early menarche. Normally, a female is supposed to start her menses somewhere around 14 years. Okay, and on average, a female is going to start her menses by 14 years. Now imagine there was this one female who is starting her menstrual cycle at 8 years. Okay, she was supposed to start her menstrual cycles from 14 years, but now our female is starting her menstrual cycle from 8 years. So how many years before she have started? She have almost started her menstrual cycles 6 years or 7 years before normal. So now 7 years of extra menstrual cycles, 7 years of extra menstrual cycles. So more the number of menstrual cycles, more possibility of retrograde menstruation. More number of retrograde menstruation, more chances of endometriosis. So early menarche is a risk factor for endometriosis, true statement. And having a first degree relative with endometriosis. Now imagine there was this one female. Okay. Now imagine if her mother is having endometriosis, means she is also likely to get endometriosis. Almost like 6 to 10 times risk is there. 6 to 10 times she is having higher risk when compared to normal females. First degree relatives, like there was this one female, her mother or her sister, if they are suffering with endometriosis, means she is also in her future, she is also more likely to develop endometriosis because some genetic predisposition is there. Okay. Now late menopause. What is late menopause, sir? Normally a female is supposed to have her menopause. Menopause means ovarian failure. Menses is going to stop. Normally, typically in India, menopause is going to somewhere occur around 47 to 50 years of age. 47 to 50 years of age, menopause is going to occur. But imagine that there was this one female whose menopause is happening at 58 years. Okay, till 58 years, she is menstruating. Now, menopause which was supposed to happen by 50 years, now in her menopause is happening at 58. So 8 years of extra menstruation. More menstruation, more chances of retrograde menstruation. More the number of retrograde menstruations, more chances of endometriosis. Okay, so a female who is having late menopause is also at a risk of developing endometriosis. Okay, I have explained you. Usually endometriosis is something happens in the reproductive age. Usually, okay, most commonly 25 to 35 years of age. But there is still, yes, possibility is there that endometriosis can also happen in older females. Okay. Now, low body mass index is a risk factor. That's not that important anyway. But Mullerian anomalies, sir. Mullerian anomalies. How to understand how Mullerian anomalies are going to cause endometriosis? Normally, you guys know from your anatomy. Okay, from your anatomy, embryology you have already studied. Sir, in the female's body, there is a duct called as Mullerian duct. There is a Mullerian duct. Normally, this Mullerian duct is the one which forms the uterus. From the Mullerian duct, uterus is derived, cervix is derived, and fallopian tubes are also derived from the Mullerian duct, no doubt. But imagine if there is a defect, during this process. Now, Mullerian duct which is forming uterus, fallopian tubes and cervix. Now, there is some mishap happened. During the process of this Mullerian duct derived into uterus, cervix and fallopian tubes, there is some problem have occurred. Now here the cervix is very much narrow. The cervix got stenosed. There is cervical stenosis. Now, whenever cervical stenosis is there, just think logically. Now, do you think the endometrium will come down easily? There is a very narrow orifice. No, endometrium can't come down into vagina properly. So, uterus is contracting powerfully. But endometrium doesn't find a way forward. So, what happens? Now, endometrium, it will start to get back into the fallopian tubes and that endometrium will spill into the peritoneal cavity. Okay, endometrium is spilling into the peritoneal cavity, causing endometriosis. So, Mullerian duct anomalies are also a risk factor of endometriosis, no doubt. And nulliparity. So, what does it mean by nulliparity, sir? Nulliparous female. A female who is not having children. In a simple way, a female who doesn't have any children. Now, how this nulliparity will account for endometriosis, or how it is a risk factor for endometriosis? Simple, guys. Normally, whenever a female is having a pregnancy, she is having almost a break of 9 months. She is having a break of 9 months. What is this break? No menses for 9 months. And even after delivery, there is 6 months. Lactational amenorrhea is there after delivery. For the next 6 months, till the time she is lactating the baby, till the time she is breastfeeding the baby, there won't be any menses. You all know this. During pregnancy, there is no menses, sir. After delivering the baby, again there is no menses, sir. So, if a female, if she have one pregnancy, almost she is having a break of 1.5 years from the menses. If she is having 2 pregnancies, almost for 3 years, she is not menstruating. Okay. So, now what is the problem with the nulliparity? Nulliparity means no pregnancy. Continuously, she is bleeding every month, she is bleeding every month, she is bleeding, her menstrual cycles are happening. So, there is no break. More the number of menstrual cycles are happening. So, more the number of menstrual cycles, more chances of retrograde menstruation. More retrograde menstruation, more chances of developing endometriosis. It's as simple as that. Now, shorter lactational intervals. Now, she is not lactating. Okay, she is not lactating the baby. Normally, after delivery, she have to lactate the baby, she have to breastfeed the baby. So, for example, if she is breastfeeding the baby for 1 year, for the next 1 year, she is breastfeeding the baby. So, that 1 year, she is not going to have menses. Lactational amenorrhea will be there. But for example, imagine that there was this one female, because of some reasons, whatever might be, she is not lactating the baby, she is not giving the milk to the baby. So, what happens? There is no amenorrhea. So, within a month or two, she is going to develop the menstrual cycles. Again, she is going to start her menstrual cycles. So, shorter the lactational intervals, more like in a very rapid time, in a very short time, again she is going to start her menses. So, more the number of menstrual cycles, more chances of retrograde menstruation, and again more chances of endometriosis. Completed, guys. And just give me 1 minute. Okay. Shorter menstrual cycles. Now, what does I mean by shorter menstrual cycles? Normally, she is supposed to have menstrual cycles every 28 days. For every 28 days, she is having menstrual cycles, which means every month she is having one cycle. Now, what is the normal range? The normal range is like, at least she should have a cycle more than 21 days. Okay, more than 21 days is something normal. Or let me put it as simple as possible. Now, there was this one female who is having menstrual cycles not for every 28 days. Now, she is having menstrual cycles for every 18 days, which means she is bleeding. She is bleeding once in 18 days. Now, what is happening? For every 18 days, she is bleeding. Sir, normally, in a year means 12 month span. How many menstrual cycles will occur? Sir, there are 12 months in a year. So, 12 times a female will bleed in a year. 12 menstrual cycles are going to happen. But if she is having menstrual cycles once in every 18 days, do you think that she is going to have 12 menstrual cycles? No, definitely not. Instead of 12, she is going to have 20 menstrual cycles. Now, 20 menstrual cycles means 20 times she is bleeding. More the bleeding, more chances of retrograde menstruation. More retrograde menstruation, more chances of endometriosis. So shorter menstrual cycles are also a risk factor for endometriosis. And last thing, the last risk factor which was observed is, it was observed, okay, according to the study, it was observed, sir, the endometriosis is going to be very much common in white race. White race means the Western people when compared to the black race. Remember, in black people, in the African people, there is the higher risk of uterine fibroids. Uterine fibroids are going to be most commonly associated with the black race. But when I am talking about the endometriosis, it's going to be most commonly seen with the Western people, that is the white race. So in this slide, I have explained to you all the risk factors. If you have any doubt, you can all the time put it in the question in the chat box. Guys, do you have any question? Have you understood what are the risk factors of endometriosis? Why endometriosis is happening? Simple. More number of menstruations are more chances of endometriosis. Okay. Come on, guys. Please, if you have any questions, you can put it in the chat box. Shall I continue, guys? Shall I continue? Okay. If you have any doubt at any time, you can put it in the chat box. Now, let's go further. So, how to put the diagnosis of endometriosis? Very simple. The diagnosis is, the investigation of choice and also the gold standard is laparoscopy. Now, what is laparoscopy? What is laparoscopy? Simple. What is endometriosis? Growing of endometrium in the peritoneal cavity or growing of endometrium outside the uterus. The most common site is ovaries and the second most common site is pouch of Douglas or cul-de-sac. Now, how to put the diagnosis, sir? Simple. Put a camera into the pelvic cavity and look for the endometrial implants. Now, you can directly see with your eye, right? You can directly see with your eye. You can directly visualize the endometrial implants. So, what is the gold standard? The gold standard is laparoscopy, sir. Here you can clearly see, sir, here is your pouch of Douglas. Okay, this is the pouch of Douglas. And this is uterosacral ligaments. Here are the uterosacral ligaments. If you can see, here are the places where small endometrial implants are there. Small endometrial implants are visualized. So, what I am trying to put into your mind is, the gold standard and the investigation of choice is laparoscopy. Why? Because you can directly visualize the endometrial implants. Having said that, I just want to show you the laparoscopic view of a normal pelvic cavity. Why I am saying this is because later I will tell you some important points. First, let's see what is the normal view in a laparoscopy. First, let's see. After that, let's try to correlate with the endometriosis. So, normally, this is your uterus. Okay, this is the place of uterus. And this is one fallopian tube. This is the other fallopian tube. Guys, please see this white structure. Whatever is there, this is the ovary. Okay, this is one ovary and this is the other ovary. Okay. Now, back to the uterus. Okay, this is the front side. Okay, this is the front side and this is the back side. Now, back to the uterus, there is this area which is present called as the pouch of Douglas, also called as cul-de-sac. Now, anterior to the uterus, what is there? Bladder is there. Posterior to the uterus, what do you have? Pouch of Douglas along with the bowels. Intestines are going to be there. Now, what I am saying is, see, this ligament, whatever I am showing you, this is the uterosacral ligament. From the uterus, there is this one ligament which is going back to the sacrum. Here also one ligament is there, this ligament, which is called as the uterosacral ligament. Uterosacral ligament. Now, why this uterosacral ligament is important, sir? Why? Because this uterosacral ligament is in very close proximity to pouch of Douglas or not. It's very near to the pouch of Douglas, sir. So, whenever the endometrium is falling, whenever the endometrium is coming out of the fallopian tubes and whenever it is coming and falling onto the area of pouch of Douglas, definitely the endometrial implants are also going to fall onto the uterosacral ligaments. Endometrial implants, they are going to fall onto the uterosacral ligaments. So, whenever you do physical examination in a female, you can actually feel the uterosacral ligaments. Whenever you are doing the bimanual examination, whenever you are putting your fingers into the vagina and whenever you are doing the physical examination, actually you can go to the area of uterosacral ligaments. Now you can feel the nodularity. Why there is nodularity? The nodularity is because of the endometriosis. So what I am trying to put into your mind is, sir, if a female is suffering with endometriosis, then you can feel the uterosacral ligament nodularity. Why? Because the endometrium is falling onto the uterosacral ligament and you can feel the nodularity on the physical examination. Okay. Now, let's see some more important laparoscopic views in a female who is suffering with endometriosis. Guys, what I am showing you is a laparoscopic view of a female who is suffering with endometriosis. Okay. Now, in the first image, what I am showing you guys, see, this is the image where you can see one ovary here and this is the other ovary, left and right ovaries. Now, are you able to appreciate this ovary is very much big in size with a lot of implants, with a lot of these blackish areas. Now, what is happening, sir? What is happening to this ovary? Sir, this female is having endometrioma. Endometrium is falling onto these ovaries. It is getting into the ovaries and falling chocolate cyst, sir. Chocolate cyst. What is chocolate cyst? Nothing but endometrioma, where the endometrium is going into the ovaries, causing chocolate cyst. Now, let's see some important points about this chocolate cyst, guys. What you are seeing here in this image is a chocolate cyst. Direct MCQ, chocolate cysts are seen in which conditions? Chocolate cyst is the condition which is seen in endometriosis, female suffering with endometriosis. Now, this chocolate cysts are example of true cysts. We all know from the basic pathology there are two types of cysts, chocolate cyst as well as pseudocyst. This is the example of true cyst. Okay, this is an example of true cyst. Why we are calling it as a true cyst? Because this chocolate cyst is having its own epithelium. This cyst is having its own epithelium. It is lined by epithelium. So any cyst which have its own epithelium, they are called as a true cyst, and the lining epithelium in this condition, the lining epithelium is columnar epithelium. So direct question, the chocolate cysts are lined by columnar epithelium. So they are called as true cyst. And in this endometrioma, what you can see is pseudoxanthoma cells are seen, sir. Pseudoxanthoma cells are seen. What are the pseudoxanthoma cells? Now, in every tissue, macrophages are there or not? Macrophages are there. Now, here also, in ovary, macrophages are there, and these macrophages, do you know what they will do? They will eat up all the endometrial implants. Endometrium is something foreign. Endometrium is supposed to be there in the uterus, not on the ovaries. Now, what these macrophages will do? These macrophages, they will come and eat up all these endometrial implants, so that now these inside the macrophages, there is blood, and the blood will be destroyed. Hemosiderin is going to form. So hemosiderin is going to accumulate inside the macrophages. So this hemosiderin laden macrophages are called as the pseudoxanthoma cells. So pseudoxanthoma cells are seen in chocolate cysts, sir, because of the presence of hemosiderin inside them. Now, having this chocolate cyst, does it going to possess any risk factor for the female? Now imagine that there was one female who is suffering with endometriosis and she is having endometriomas, ovarian endometriosis. Now, she is at risk of developing cancer, sir. In her future, she is going to develop ovarian cancers. There are different types of ovarian cancers, out of which she is at a risk of developing clear cell carcinoma of the ovary or endometrioid variety of cancer, endometrioid variety of ovarian cancer. So, what are the two important ovarian cancers which can be developed by a female who is suffering with endometriosis? Two types, sir. Clear cell carcinoma. Second type is endometrioid variety of ovarian cancer. Now, last point is how to manage. Now, what to do, sir? What to do with this chocolate cyst? Is this chocolate cyst going to be treated with tablets? Medical therapy is enough? No, chocolate cysts are not going to be treated with. They are not going to be resolved with medical therapy. You need to do the surgery. That is a laparoscopic cystectomy. You have to do the cystectomy. Chocolate cyst, it need to be taken out. That is cystectomy, laparoscopic cystectomy. Now, in the second image, please concentrate, guys. In the second image, this is the laparoscopic view of a very severe endometriosis. Now, what is happening here? Sir, whenever there is endometriosis happening, endometrium is growing in the pelvic cavity. Now, this endometrium, this is the bad endometrium, which is coming out of the uterus. It is growing in a place where it was not supposed to be. Now, this endometrium, do you know what it will do? This unwanted endometrium, it will cause inflammation inside the peritoneal cavity. It's going to cause inflammation in the pelvic cavity, peritoneal cavity. Wherever this ectopic endometrium is there. Wherever do you find this ectopic endometrium, it will cause inflammation. So in the pelvis there is inflammation, in the peritoneal cavity there is inflammation. So whenever you have inflammation in the pelvis and peritoneal cavity, what do you have ultimately? Because of this inflammation, there is formation of adhesions. When the inflammation is getting treated, when the inflammation is getting resolved, the inflammation resolves with scar tissue. So at the end, adhesions are going to form, and lots, this is the main problem, guys. Lots and lots of adhesions are going to form in the pelvic cavity. Here you can see all these adhesions, unnecessary adhesions. Okay, all these adhesions are going to form. And also you can clearly see all the sites, the endometrial implants, they are bleeding. Endometrial implants, they are bleeding. Now it will give you an appearance called as powder burn appearance. So powder burn appearance is seen in which condition? Powder burn appearance in the pelvic cavity is seen in which condition? Endometriosis. Chocolate cysts are seen in which condition? Endometriosis. Pseudoxanthoma cells are seen in endometriosis. Okay, these are some important points. Remember, just like a normal endometrium, this endometrial implants, they will also bleed. They will also bleed. So all the fluid will come whenever they bleed. This fluid will come and accumulate in the pouch of Douglas. So you can see fluid accumulation. So a female who is having this endometriosis quite oftenly have a peritoneal cavity, like fluid in the peritoneal cavity. Okay, brown fluid which is present in the peritoneal cavity, which is this blood, which is the blood, the endometrial blood, which is coming and accumulating in the peritoneal or the pelvic cavity, especially in the pouch of Douglas. So here I have shown you a laparoscopic view of endometriosis, so how it is seen, sir. Now after this, I want you to understand the clinical features. Staging is not that important. Important is the clinical features. Important point is with the clinical features. Now, sir, there is this one female who is suffering with endometriosis. What is her main problem? What is her main problem? Try to understand like this. Normal menses itself is painful. There is no doubt. Normal menses itself is painful. But this female is having extra endometrium, unwanted endometrium in different places. So just like a normal endometrium which will shed, this endometrium will also shed. So extra endometrium, extra shedding, so extra pain. So a female who is suffering with endometriosis, her main problem, her main concern is painful menses, very much painful. So every time she is bleeding, she is having excessive pain. So this is called as dysmenorrhea. She is suffering with dysmenorrhea. That is secondary dysmenorrhea. Primary dysmenorrhea is what? Primary dysmenorrhea is something normal. Every female during menses, she is going to have her pain. So that is normal dysmenorrhea or primary dysmenorrhea. Now pain is there because of a pathology. Whenever you have pain during menses because of some pathology, that is called as secondary dysmenorrhea. Okay, now our female with endometriosis is going to have secondary dysmenorrhea and her main symptom is pain, sir. After pain, what are the other concerns? Now this female who is in her reproductive age group, whenever she tries to conceive, whenever she wants to have a baby, pregnancy is not happening. Why pregnancy is not happening? See, there is infertility. Why pregnancy is not happening? Guys, unnecessary inflammation in the pelvic cavity. Unnecessary inflammation means unnecessary production of chemical mediators. These chemical mediators can kill the sperms. These chemical mediators can affect the quality of ovum. Okay, now inflammation is there. That inflammatory environment is not suitable for pregnancy to happen. Or try to understand like this. Sir, during endometriosis, what is happening? Inflammation in the pelvic cavity. Lots of adhesions are forming. All these adhesions, normally, see, imagine this is the fallopian tube. Imagine this is the fallopian tube. Here is the ovary. So fallopian tube, all the fimbriae, they are in a very close proximity to the ovary. This is the ovary. So whenever the ovary releases the ovum, that ovum is going to be it's going to be caught by the fallopian tube. Okay, the fimbriae are going to get the ovum, it's going to catch the ovum. So now what happens in endometriosis? Sir, inflammation, adhesion formation. So what happens? Because of the adhesions, the tubo-ovarian relationship, the tube and ovary, the tubo-ovarian relationship is distorted because of the excessive scar tissue. The scar tissue is moving the fallopian tubes away from the ovary. Now, ovary is producing the ovum. Ovum is coming out of the ovary, but that ovum is not entering into the fallopian tube. Now, what happens? Do you think fertilization will happen? No fertilization, no pregnancy. So, her main two problems are, one is pain. If she is not married, if she is not if she is not a married woman, her main problem is going to be, sir, pain. If she is married and if she is trying to get conceived, pregnancy is not happening, infertility. Okay. What else can be seen, sir? The two important features I have taught you. Now, what else can be seen in this female? What other clinical features? She is going to have dysperonia. Now, what is this dysperonia, sir? Dys means painful. Peronia means coitus. So, dysperonia means, now whenever this female tries to engage herself in sexual activity, whenever she is indulging in sexual activity, she is feeling so much pain. Okay, she is going to cry out with the pain. Now, why she is having pain? Guys, here in this image, I have represented why she is having pain. Guys, see. Now, during the sexual activity, here I have shown you the sexual activity where the penis is getting inserted into the vagina. But why she is having pain, sir? Now, you all guys know this area where I am highlighting with the red color. What is that area? Sir, the area which I have highlighted is back, see this area. This area is back to the uterus. What is this area, guys? I am asking you. I am checking the comments. What is this area, sir? Which I am just rounding up. What is this area? This is back to the uterus. All the fluid will come and accumulate here. What is that area? Pouch of Douglas. Okay, or the cul-de-sac. Pouch of Douglas or the cul-de-sac. Now, pouch of Douglas is the second most common area for endometriosis. It's the second most common area for endometriosis. So, endometriosis is going to be most commonly happen here. Okay, second most commonly going to happen here. So, here all this area is inflamed with lots of adhesions, lots of chemical mediators, lot of inflammation is there. So, whenever sexual activity is happening, whenever the coitus is happening, definitely this area is going to be stretched. Definitely that area is going to be stretched. The inflamed area is now getting stretched. So, does this female is going to have pain or not? Definitely she is going to have her pain. Why? Because this area, pouch of Douglas, is involved. So, her second most common, her other clinical features are going to be dysperonia. So, whenever in your exam, whenever you see this word, dysperonia is there. A female, a reproductive age group female. Now, she is having pain during her menses. She is infertile, she is having infertility. She is trying to conceive, but from the last 6 months, she is not getting pregnancy. Also, she is complaining that with every sexual activity, she is having pain, dysperonia. Think about endometriosis. Okay. Along with that, what else she can have? She can also have menorrhagia, excessive bleeding. Excessive bleeding is there, but that's not that common. Anyway, one important point. She can also have menorrhagia, excessive bleeding. Okay, lots and lots of bleeding. She is bleeding. This is not seen in every female. In some females, menorrhagia is also noted. Now, after saying this, let's discuss about why this female is having pain. Already, see, I have explained to you little bit why there is pain. The pain is because extra endometrium, that extra endometrium will also shed. It will cause the pain. So, there is focal bleeding. There is bleeding from the endometriotic implants. All these endometriotic implants are there, right? They will also shed. They will also cause bleeding. But important point is, sir, imagine this is the ovary. Okay, whatever I am showing you, this my hand area, this is the ovary. Now, endometrium is falling onto the ovary. Endometrium, via retrograde menstruation, it is falling onto the ovary. Do you know what these endometrial implants will do? Sir, these endometrial implants, now they are having this nature. They will go deep into the tissue. They will invade into the tissue. So, in the ovary, they are going into the ovaries and forms endometrioma. Now, in the pelvic cavity also, what they will do is, they will dug deep into the tissues. Whenever they are going deep into the tissues, all our body organs are innervated by nerves. Now, these endometrial implants, whenever they are invading into the tissue, they will irritate the nerves. So, nerves are irritated. That will cause the pain. So, very, very important, which is, so the direct involvement of the nerves which are present on the pelvic floor. The endometriotic implants, they will go deep into the tissues. They will affect the pelvic nerves. They will irritate the pelvic nerves. that causes pain. So pain is directly proportional to the depth of the lesion. More depth, more the lesions are going in, more nerves are irritated, more pain will be seen. This is the MCQ. The pain is directly proportional to the depth of the lesion. Along with that, already I have explained you that this endometriosis, these endometrial implants will cause the inflammation, So there is production of inflammatory cytokines, inflammatory mediators are produced. These inflammatory mediators will cause pain. We know prostaglandins will cause pain. Inflammation is there, prostaglandins are getting produced. These prostaglandins will cause pain. Okay, now the main problem with the endometriosis is pain. Now after that, let's see why there is infertility. I have already explained you why there is infertility. Sir, in endometriosis, there is inflammation. Whenever there is inflammation, there is a distortment of tubo-ovarian relationship. The tubes and the ovaries, they are distorted. The tube and the ovary, they are moved away from each other. So now this fallopian tube, it's not able to catch the ovum. So she is suffering with infertility. Also, this female is having a chronic inflammation going on in her pelvic cavity. Due to chronic inflammation, there is production of inflammatory mediators. These inflammatory chemicals, all these are chemicals, right? These chemicals will interfere with the process of fertilization. These chemicals will affect the quality of ovum. These chemicals can kill the sperm. So that can lead to infertility. So the second most common presentation of endometriosis is infertility, which is seen in almost 30 to 40% of the females. So 30 to 40% of the females are going to suffer with this infertility if they are having endometriosis. Okay. Now, after discussing about the clinical features, now she came to your clinic. Okay. Now you are a gynecologist. Now this female is coming to your clinic and she is saying, first thing, sir, my age is 30 years. So she is reproductive age group. Now our reproductive age group female, she came to your clinic, she came to your OPD and she is saying, with every menstruation, she is having pain. That is secondary dysmenorrhea is there. Okay. And she is also complaining. She is having pain during sexual activity. That is dysperonia is there. And she have married for the past 2 years and she is not getting the pregnancy. That is infertility is there. So what you are thinking? Now in your mind, now you start to think about endometriosis. Now, what you will do as a doctor? Definitely you have to do certain physical examination. Now, what you are doing is, you are trying to look at the uterus. Okay, now you are looking at the uterus via physical examination. You just want to feel whether everything is okay with the uterus or not, or you just send the patient to the ultrasonography. You have sent the patient to ultrasonography. What you can see is most of the times the uterus is retroverted. What does I mean by? Normally uterus is anteverted. Normally, see in this image it's very clearly shown, whatever I am highlighting right now with the yellow color. This is how a normal uterus will be. The uterus is falling onto the bladder. Actually, the uterus is anteverted. Uterus fundus, the uterine fundus is actually falling onto the bladder. This is anteverted uterus. But in the condition of endometriosis, what happens? Sir, everywhere there is inflammation. Now inflammation is going to be resolved with fibrosis. Unnecessary scar formation is happening. Unnecessary fibrous tissue is getting formed inside the pelvis. Now, clearly see here, these are the adhesions. Right now I am pointing out the adhesions. The adhesions are forming on the uterus and the adhesions are also attached to the sacrum. So because of the adhesions, what is happening to the uterus? The uterus is pulled back. So what is happening? Sir, there is retroversion of the uterus. These adhesions, they are pulling the uterus back. Previously we have discussed, because of the adhesions there is distortion in the tubo-ovarian relationship. The tubes are moved away from the ovaries. So tubo-ovarian relationship is affected, right? In the same way, now uterus is going back. So this is called as a retroverted uterus, which is seen because of the adhesions. Now, along with that, so whenever you try to palpate the uterosacral ligament, previously I have explained you guys, uterosacral ligament, it's very near to the cul-de-sac. So what happens? Now on to the uterosacral ligament, this endometrium is growing, it will form small nodules. So whenever you are trying to palpate, okay, you have put your fingers in the vagina and you are trying to check. So on the uterosacral ligaments, you will feel the nodularity. So small nodules. So what is happening? The endometrium is growing on the uterosacral ligament. That gives you uterosacral ligament nodularity, which we will say also called as the cobblestone field. Cobblestone field, like small stones. The cobblestone field, which is a senequinon, which means without which endometriosis will never happen. In all the cases of this endometriosis, you can feel that uterosacral ligament nodularity. It's such a characteristic feature. So it's a senequinon feature of endometriosis. What is that? Uterosacral ligament nodularity. Now after this, what else we can see? Sir, in the endometriosis, ovaries can be affected. Ovaries, what will happen? Endometrioma will happen. Ovaries will become enlarged with the chocolate cysts. So in the adnexa means surrounding regions of the uterus, simple. So in the adnexa, what you can feel? Sir, in the adnexa, you can feel enlargement. So there is enlarged adnexa, might be because of endometrioma. As there is inflammation going on in her body, whenever you order for the laboratory test, WBC count is more, erythrocyte sedimentation rate is more. WBC count is more because inflammation is happening in her body. ESR will be elevated, erythrocyte sedimentation rate will be elevated because of inflammation. And also CA125 levels will be elevated. So what is the CA125? This is not that important. Why? Because CA125 is a marker which is elevated with other conditions also. Sir, in endometriosis, CA125 levels are elevated, no doubt. But the CA125 is something which is elevated even in other conditions. So this is non-specific. CA125 levels are going to be elevated in uterine fibroids, pelvic inflammatory disease, pelvic TB, epithelial carcinoma of the ovaries. So in all these conditions, CA125 levels are elevated. It's just a marker. So here in this condition also, in the blood, CA125 levels, it's a chemical marker. It will be elevated. So anyway, what you need to know is the senequinon feature, the characteristic feature is uterosacral ligament nodularity. Adnexa will be enlarged because of the endometrioma, as well as you can have retroverted uterus. See, important guys, retroverted uterus in endometriosis. Now after this, the main part, how to treat this condition, sir? So the main problem of this female is pain. With every menses, she is having pain. So what we have to do, whenever she is having pain, only pain, now the drug of choice is going to be NSAIDs, non-steroidal anti-inflammatory drugs. So non-steroidal anti-inflammatory drugs are the drug of choice whenever she is having only pain. Now what else can be used in the treatment of endometriosis? Oral contraceptive pills. They are contraceptive pills, guys, contraceptive pills. What are oral contraceptive pills? Nothing but a combination of estrogen and progesterone. Now my question is, how these oral contraceptive pills are going to treat her symptoms? Her main symptom is pain. Whenever she have endometriosis, she is having pain. Whenever she is having menses, see, whenever she have menses, that time she is having pain. So now what I am going to do is, I am going to stop her menses. Not a problem, not a big deal. I am going to stop her menses for the next 3 months or 4 months. So now she is not menstruating, so she is not having any pain. See, very simple. So what I am going to do is, I am going to give drugs like oral contraceptive pills. Whenever you give oral contraceptive pills in a continuous manner, continuously, normally, normal females, whoever doesn't want to have any pregnancy, normal females, they use oral contraceptive pills. Okay, why? They don't want to have pregnancy. Normally, how they will take these pills? They are going to take these pills for 21 days. In a month, they are going to take these pills for 21 days. For the next 7 days, they are going to stop the pills. So whenever they stop the pills, menstruation will happen. Everyone knows this. Oral contraceptive pills are taken for 21 days. The last 7 days in a month, they are not going to take any pills. So menses will happen because of the withdrawal of the oral contraceptive pills. Menstruation will happen. Right now, what I am doing? I am going to give the oral contraceptive pills continuously for 3 months. So there is no withdrawal of hormones. So continuously what I am doing? I am giving her estrogen plus progesterone. So 3 months in her body, there is progesterone. So till the time she have progesterone in her body, there is no menses. Normal physiology is what? So whenever progesterone levels goes down, menses will happen. Now what I am doing? I am continuously supplying the progesterone, continuously 3 months. So 3 months there is no menses. So 3 months there is no pain. So she is going to have menses when? Sir, once in 90 days, she is going to have her menses. I have treated her pain. Now, what else drugs can be given, sir? Aromatase inhibitors. Can you give me one example of aromatase inhibitors, guys? Can anyone give me an example of aromatase inhibitors? Can anyone give me example of aromatase inhibitors from your pharma guys? Arthur, Rishi, Najib, Ravis. Can anyone give me example of aromatase inhibitors? Come on guys, I'm checking your comments. You don't know? You don't know? So the aromatase inhibitors include letrozole. Okay. So letrozole is a drug which is an example of aromatase inhibitor. Now how this aromatase inhibitor is going to help us in this condition? How, sir? See, our main problem is this endometriosis. Endometrium is growing. Normally, what is the food for endometrium? What is the stimulus for endometrium? Estrogen, sir. Estrogen is the one responsible for growing the endometrium. Now, what our letrozole will do? Sir, letrozole will inhibit the peripheral conversion of androgens to estrogens. Normally, in a female body, androgens will be converted into estrogens. Androgens are going to convert it into estrogens. This is called as peripheral conversion. So androgens are converting into estrogens. Now what letrozole will do? Will inhibit the conversion of androgens into estrogens. So what happened to estrogen concentration? The estrogen concentration is going down. Whenever estrogen concentration is going down, there is no stimulus for endometrium. Whenever there is no stimulus for endometrium, endometrium won't grow. The ectopic endometrium, it's not growing. It will undergo atrophy. So to treat endometriosis, you have to decrease estrogen levels. Simple. If you decrease the estrogen levels, endometrium also will undergo atrophy. So this is one way how to treat the endometriosis. Now, what are the other drugs which we can be given? Sir, progesterone drugs. Progesterone drugs like Dmpa. Dmpa is an injection. Okay. Dmpa is a progesterone injection. Dmpa is a progesterone injection. How progesterone is going to helpful in this condition, sir? Normally, progesterone, till the time you have progesterone in your body, till the time progesterone is there in the female body, menstruation will never happen. Menstruation will never happen. So, now what I am going to do to this female who is suffering with endometriosis is, I am going to give her powerful progesterone injections. Now, this progesterone, what it will do, you know? This progesterone actually will cause decidualization of endometrium, or this progesterone, high levels of progesterone will cause atrophy of the endometrium. This is one point. So there is atrophy of ectopic endometrium. There is atrophy of ectopic endometrium which is there in the body. Second thing is, till the time you have progesterone in your body, there is no menses. When you don't have any menses, there is no pain. So I am going to give an injection called as the Dmpa injection, 150 milligrams once in every 3 months. Okay, once every 3 months, she is going to come to the clinic and she is going to take an injection called as Dmpa. Okay, it's a medroxyprogesterone. Dmpa is called as a medroxyprogesterone. Now, whenever she takes this medroxyprogesterone, high levels of progesterone, it will cause decidualization, also called as simply atrophy. Atrophy of the endometrium. There is no menses. There is no pain. Simple, completed. The next group of drugs which can be used to treat the endometriosis is GnRH analogues. GnRH analogues. Can you tell me one GnRH analog, guys? Example of GnRH analog. The drugs which are acting like GnRH. Anyone? If you are really good, just tell me. Examples of GnRH analogues. Examples of GnRH analogues. I will give you one example. Leuprolide, goserelin, buserelin, nafrelin. So drugs which are ending with the name relin, GnRH analogues. We all know from pharmacology, okay, from our basic subject. So whenever you use GnRH, gonadotropin releasing hormone analogues, in a continuous dose, the word important is a continuous dose. Whenever you use GnRH analogues in a continuous dose, what happened to FSH levels? Sir, FSH levels goes down. What happened to LH levels? LH levels goes down. So continuous stimulation will desensitize the receptors. So FSH levels goes down, LH levels goes down. So how this is helpful? Whenever there is no FSH, automatically estrogen levels goes down. Why? Because follicle stimulating hormone, it stimulates the follicles. Okay, it's acting on the ovary, it stimulates the ovarian follicles. Now, developing ovarian follicles are the ones which produces the estrogen. So, whenever there is no FSH, follicular development is not there. So, estrogen is not there. Whenever there is no estrogen, the ectopic foci, the ectopic endometrium is undergoing atrophy. So, we have to decrease the estrogen levels. Whenever there is no LH, there is no ovulation. Whenever there is no ovulation, there is no menstruation. Whenever there is no menstruation, there is no pain. So I am treating her pain, guys. So GnRH analogues, okay, GnRH analogues, they will down regulate the entire hypothalamo-pituitary ovarian axis. So when you have to give GnRH analogues in a continuous way, they will greatly reduce the estrogen levels. But there is some problem. Guys, this female is suffering with endometriosis. So you are giving GnRH analogues in a continuous dose. So what is happening in her body? You are decreasing the estrogen levels, no doubt. And this decreasing in the estrogen levels treats the endometriosis. Okay, it treats the endometriosis, no problem. But whenever you decrease the estrogen levels in her body, what will happen? Normally, estrogens are osteoprotective in nature. Estrogens inhibit the osteoclasts in her bone, so that there is no osteoporosis in a normal healthy female. But what you are doing? You are decreasing the estrogen levels. Decrease in estrogen levels will treat endometriosis, no doubt. But in her bones, what will happen? Now she will start to have osteoporosis. So what you need to do? You need to give little bit amount of estrogens. So you have to keep these females on low dose estrogens. You have to give low dose estrogens to prevent osteoporosis. Why? Because GnRH analogues, they are very powerful drugs. They are going to bring down the estrogen levels so low. Now she start to have another pathology, another problem, that is osteoporosis. So to treat osteoporosis, we have to add back a little amount of estrogen. So this is called as add back regime. We have to give her raloxifene. Okay, low dose estrogens are given like raloxifene, little amount of raloxifene we are giving. Okay. Now, lastly, the last group of drugs which can be used in the treatment of endometriosis is the danazole. Can you tell me what kind of drug is danazole? What is the mechanism of action of danazole? How this danazole is going to treat endometriosis? Can anyone, guys? Can anyone tell me how danazole can treat endometriosis? What kind of drug is danazole? Come on, Dikshita, what kind of drug is danazole? Arthur, Clinton, anyone? Ravis, what kind of drug is danazole? Come on, Dikshita, what kind of drug is danazole? Sir, danazole is an androgen drug. Danazole is just like an androgen. Now, why we are giving this danazole in this condition? Why? Because see, danazole is a androgenic drug with anti-estrogen properties. Very important. Danazole, it's an androgen, synthetic androgen with anti-estrogenic properties. So anti-estrogenic, against estrogens. In the condition of endometriosis, we don't want estrogens. So this danazole, it is anti-estrogenic. It's having anti-estrogenic properties. So what it will do? It will decrease the FSH, it will decrease the LH, it will decrease the estrogen levels in the body. So whenever you decrease the estrogen levels, ectopic endometrium will undergo atrophy. Whenever you take out that ectopic endometrium, problem is solved. Okay, so these are the treatment options which are available for the endometriosis. Some important points which you need to know for your exam. Now after this, let's talk about the surgical management. So far what we have discussed in the previous slide, we have discussed about the medical management, how to treat endometriosis with drugs like GnRH analogues, like with the danazole, or with the non-steroid anti-inflammatory drugs, or with the progesterone drugs. We have seen what is the treatment. Now let's talk about the surgical management. Now if she is having severe endometriosis, she is having so much pain, She's having so much amount of implants. So what we are going to do is, we are going to burn, we are going to ablate. Ablation means burning. We are totally frying, okay, frying up. This is the normal word. We are totally frying or burning down the ectopic implants. That is called the fulguration. So ablation of the endometrial deposits by cautery. I am going to burn out all the endometriotic implants, okay, and that will definitely going to treat the heart symptoms. Okay, now after this, what else I can do? Sir, in the condition of endometriosis, there is so much chronic inflammation is happening in her pelvic area that will cause adhesions. Now these adhesions are going to distort the tubo-ovarian relationship. These adhesions will cause retroverted uterus. These adhesions will cause retroversion of the uterus. Retroversion of the uterus is very bad. Whenever the uterus is retroverted, it can fall down through the vagina. The retroverted uterus is a very important risk factor for uterine prolapse. So what I have to do? I have to take out these adhesions. So the surgery is called as adhesiolysis. So laparoscopic adhesiolysis can be done. Or what else can be done? Sir, she is having pain, right? She is having pain. Now, all these pain sensations are going to the central nervous system via the pelvic nerve. Which pelvic nerve, sir? Uterosacral nerves. Uterosacral nerves are the pelvic nerves which are carrying the pain sensation to her central nervous system. Actually, she is feeling pain where? She is actually feeling the pain in her brain. Okay, all the pain signals are going to the central nervous system. She is actually feeling the pain in her central nervous system. Now, what we have to do? We have to cut down these tracts. We have to just ablate, just destroy the uterosacral nerve. Whenever you destroy the uterosacral nerve, the pain sensations are not being transmitted to the central nervous system, so she cannot feel the pain. So, Luna, laparoscopically, you are destroying the uterosacral nerve. That is laparoscopic uterosacral nerve ablation, Luna surgery. It can be done. And lastly, whenever she have the big endometriotic implants in the ovary, that is endometrioma, big endometrioma. The chocolate cyst is there. I have already explained you cannot treat the chocolate cyst by tablets. She have to go with the cystectomy. So chocolate cysts can be surgically treated with cystectomy. Okay. And what about the infertility? How we can treat her infertility? Now the second most common presentation in the topic of endometriosis, in the problem of endometriosis, is infertility. Now what we have to do for this female? I have said you, sir, because of the chemicals, she is not ovulating. First of all, because of the chemicals, unnecessary inflammation, she is not ovulating, or there might be distortion in the tubo-ovarian relationship. So what we can do, sir? See, whenever she is having mild endometriosis and she is not ovulating, now we have to make her ovulate. We have to give certain drugs with which she is now going to ovulate. So in mild endometriosis, what we can do is we can give her drugs like clomiphene citrate. Now this clomiphene citrate, what it will do? It will cause superovulation. Now whenever you use this drug clomiphene citrate in this female, now she is going to release more ova, not one ova. Now she is going to ovulate 3-4 ova. Now out of this 3-4 ova, at least one ova is going to enter into her uterine cavity and it will undergo fertilization. Now you can try this superovulation with the clomiphene citrate. You are giving her clomiphene citrate. Now for 3 cycles you are trying. Okay, you are giving clomiphene citrate. Okay, you are giving clomiphene citrate, and what you are doing is, see, you have given the clomiphene citrate. Now she is ovulating. Now she have ovulated 3-4 eggs, 3-4 ova are there. Now either these 3-4 ova can be fertilized on their own. What you will do is, after giving this clomiphene citrate, now you are going to collect those ova. Okay, you are going to collect those ova. You are going to fertilize this ova in the laboratory, and you are going to put this ova into the uterus. So this is called as you are going to put this ova into the uterus. In vitro fertilization. Or what else we can do? Sir, first thing, you have given clomiphene citrate. Now she is super ovulating. Now whenever she super ovulates, whenever she produces more ova, there is increased chance of fertilization. That one thing you can do. Or what else you can do? You have given the clomiphene citrate, you have collected the ova, you have done in vitro fertilization, and you have kept this ova again back into the uterus. This is one way you can do. Or what else you can do? You have given the clomiphene citrate, she have superovulated, she have produced more ova, and this ova are coming into the uterine cavity. Now what you have done is intrauterine inseminated. Okay, you have done intrauterine insemination. What is intrauterine insemination? You have collected the semen from the partner, you have directly injected the semen into the uterus. So ova are coming, you have injected the sperms into the uterine cavity, that is intrauterine insemination. So all these things you can do. What I am trying is, you have done all these things to make her pregnant. You are doing this, but all your attempts are going in vain. All your attempts are not successful. So first time you have done, fail. Again you can do. Again fail. Again you can do. So for 3 cycles you can do. You can do this for 3 cycles. Okay, you can do this for 3 cycles. If all your attempts are failing, means the last choice which you are left with is in vitro fertilization. In vitro fertilization in moderate and severe endometriosis, what you can do is in vitro fertilization. That's the last option. But mostly there is no need to go till in vitro fertilization. Just by giving this clomiphene citrate, she will produce more eggs. One of that egg will be fertilized and her problem of infertility will be treated. So the topic of endometriosis is completed, guys. We have discussed from the basics till to the management. So all important points about endometriosis are completed. Now let's take a break of 5 minutes and let's start a very important topic, which is polycystic ovarian syndrome, which is very much common in our females, which is very common in our females. 1 out of every 5 female is suffering with the polycystic ovarian syndrome. What is polycystic ovarian syndrome? In which age group it is going to come? What are the main clinical features? How to treat polycystic ovarian syndrome? We will discuss in the next topic. Okay, guys, let's take a break of 5 minutes. See you in 5 minutes. Thank you. Welcome back, guys. Yes, actually, I thought to give you 5 minutes break, but I just check the time. It's almost 8 o'clock. Okay, it's almost 8 o'clock. Sorry, it's 8:30. Okay, it's 8:30. Already we are getting late, guys. So I know you guys also want to go and have your lunch. Sorry, you guys have to go and have your dinner. So I just don't want to waste your valuable time. Let's continue with the second topic, that is polycystic ovarian syndrome. Now, this polycystic ovarian syndrome is also called as Steen-Leventhal syndrome. Okay, polycystic ovarian syndrome, the other name, Steen-Leventhal syndrome. Now, why does this polycystic ovarian syndrome happens? Why it happens? See, there are many theories, but the etiology is unclear. The etiology is unclear. First itself I am saying, we don't know the exact reason why polycystic ovarian syndrome happens. We have many theories which we will discuss, but the etiology is still unclear. There are lots of environmental factors which are associated with the PCOS. Lot of environmental factors plays an important role in the development of PCOS, and genetic factors, especially if she is having any gene defects like DEND-A1 gene or THADA gene mutations are associated with the development of PCOS. Not important for your exam, but what I am saying is there are many etiologies which are not clear explaining polycystic ovarian syndrome. And remember, the polycystic ovarian syndrome is very much common, and 1 out of every 5 females is suffering with this condition, PCOS. And PCOS, remember, it's the most common cause of infertility in the woman. What is the most common cause of infertility in the woman? PCOS. In your relatives, if they are suffering with infertility, you should have to first think about whether she might be suffering with PCOS or not. PCOS is very common, and PCOS is the first most common cause of infertility. The pathological cause of infertility is PCOS. Now, what is happening is PCOS, sir? How to put the diagnosis? What are the clinical features? Now, in the next slide, let's concentrate. The diagnostic criteria for the PCOS is called as Rotterdam's criteria. There are actually three criteria. Out of which at least you need to have 2. Out of 3, you need to have 2 symptoms. Now, what are these 3 symptoms? Now, see guys here, the mnemonic which I used to keep myself is HOP. HOP are the symptoms. What are these HOP symptoms? We will see now. Sir, H. Usually, the females who are suffering with polycystic ovarian syndrome, they have this hyperandrogenism. They suffer with hyperandrogenism, sir. Hyperandrogenism means whenever you check their serum levels of androgens, whenever you check the serum levels of androgens, they are going to have high levels of, whenever you check the serum levels of androgens, they will be very much elevated. Hyperandrogenism is seen. H. Now, what is O? Oligomenorrhea or amenorrhea. Normally, every female, normal healthy female, she is going to menstruate once in every 27 days. Every month she is going to menstruate, but these females who are suffering with PCOS, they won't menstruate. That is called as oligomenorrhea. Every month they are not menstruating. They are menstruating once in every 2 months or once in every 3 months. So this is oligomenorrhea. Or sometimes these females are not menstruating at all. Now you will get it out. Sir, why there is hyperandrogenism? Why she is not menstruating? We will discuss. Don't worry. But what I am saying, directly you are putting the diagnosis. Out of 3, she should have 2 symptoms. What are the 3 important symptoms? One is hyperandrogenism, H, O for oligomenorrhea or amenorrhea, and P for, whenever you look at the ultrasonography, see, in her ovaries, you are seeing the small cystic dilations. So polycystic, the name itself is there, it's a polycystic ovarian syndrome. Now, in the ultrasonography, you are seeing this polycystic ovarian morphology. So, out of these 3, at least 2 you need to have. See, most of the students will think, sir, in every polycystic ovarian syndrome, the female is going to have this small cysts in her ovaries. Not every female will have this. Not every female will have this. Only if you have, see, only if the female is suffering with oligomenorrhea and she is suffering with hyperandrogenism, she is only having these 2 features. Now you've done the ultrasonography. Ultrasonography is absolutely normal. Then also you have to put the diagnosis of PCOS. Now she is suffering with PCOS. Just hyperandrogenism features, excessive amount of androgens in her body, along with the oligomenorrhea is enough to put the diagnosis. That's it. There is no need of polycystic ovarian morphology in every case. Okay. So having said that, let's see what are the other features which are usually seen in PCOS females. Do you know which females are at a risk of developing this PCOS? Obese females. Those females who are obese, fat, fluffy, they will develop this PCOS. Okay, PCOS means no menses, sir. Every month there is no menses. There is no proper timing for the menses. Oligomenorrhea, amenorrhea. Whenever you look their blood levels, they will be having higher level of androgens. Hyperandrogenism. This hyperandrogenism, do you know what it will do? So whenever she suffers with hyperandrogenism, she will develop hirsutism. Sir, whenever the female is having higher level of androgens, she will have abnormal facial hair. Hirsutism is going to be seen. She will develop acne. Why she is developing acne? Because of the androgens in her body. Androgens are the ones responsible for acne. Androgens are the ones responsible for hair development. So hyperandrogenism is causing excessive hair growth on her body, that is hirsutism on the face, excessive abnormal facial hair, acne will be seen. Even sometimes she can have alopecia, loss of hair can happen. So all these are going to be seen in which female? Mainly obese females, guys. Usually PCOS females are little obese. It's not something like PCOS is only going to be happening in the obese females. No, PCOS can also happen in thin females or lean females, but mostly PCOS is happening in obese females. Obesity is going to be seen, and these females are going to have symptoms of insulin resistance. They are also going to suffer with insulin resistance, that is hyperglycemia. They are having insulin resistance, hyperglycemia. Whenever you look at the blood levels of glucose, they are having high levels of glucose in her body. So these are some important features, but remember, obesity, insulin resistance, are they criteria for putting the diagnosis of PCOS? Are they criteria for putting the diagnosis of PCOS? No. The only criteria is HOP, hyperandrogenism, oligomenorrhea or amenorrhea, and P for polycystic kidney morphology. These are the only 3 Rotterdam criteria. Now, having said that, now let's really discuss why PCOS is happening, sir. There are theories. Why really PCOS is happening? The main culprit for the PCOS is high levels of estrogen. High levels of LH. No, we don't know the reason why. We don't know the exact reason why. Now, in this female's body, high levels of LH is there. High levels of luteinizing hormone is there. Now, what this high levels of luteinizing hormone is doing? What is this LH doing? Now, we all know, normally in a female's ovary, okay, see, this is the ovary. In the female's ovary, follicles are there or not? Follicles are there or not? Developing follicles are there. Eggs are there. Now, these follicles are surrounded by granulosa cells, we know it. Now, granulosa cells are further surrounded by theca cells, we know it. Follicles are surrounded by granulosa cells. Surrounding the granulosa cells, there are theca cells. Important point is, what is the function of theca cells? Theca interna cells. What is the function of theca interna cells? They are the ones produce the androgen. In a female, androgens are there or not? Yes, sir. Normal females are also having androgens. But these androgens are converted into estrogen. In a female body, androgens are produced, but the androgens are converted into estrogens. In the adipose tissue, in the female body, adipose tissue is there or not? Adipose tissue is there in the abdomen, in the breast, in the buttocks, in the thighs. Adipose tissue is there. In the adipose tissue, androgens will be converted into estrogen. This is called as peripheral aromatization. But forget about it. Right now, what I am saying, sir, in this female who is suffering with PCOS, the main culprit is high levels of LH. These high levels of LH, the LH will stimulate, LH normally stimulate theca interna cells. Whenever LH is stimulating the theca interna cells, normally also, theca interna cells produce which hormones? Androgens. But right now in our case, there is excessive amount of LH. There is excessive stimulation of the theca interna cells. Now, theca interna cells are producing excessive amounts of androgens. Now, this is the reason why the female is having excessive amount of androgens. Now, what these androgens will do? Sir, these androgens are the ones responsible for hirsutism in the female. These androgens are the ones responsible for acne in the female. These androgens are the ones responsible for alopecia in the female. Okay. Now, okay, these androgens are causing the features of hirsutism. Now, these excessive amount of androgens, what will happen? Sir, we have studied, I have already taught you, the androgens are going to be converted into estrogens in the female or not? Yes, sir, the androgens are converted into estrogens. Which type of estrogen especially? Especially E1, sir. E1 type of estrogen. There are 3 different types of estrogens. E1, E2, E3. Estrone, estradiol and estriol. 3 types of estrogens are there. Now, during the process of peripheral aromatization, androgens are mainly converted into what? Mainly converted into E1, sir. Estrogen type 1. So now my question is, a female who is suffering with polycystic ovarian syndrome, she will have high levels of estrogens or low levels of estrogens? High levels of estrogen is there, sir. There is hyperandrogenism is there in the female. Along with the hyperandrogenism, she is also have hyperestrogenism. Hyperestrogenic states are there. Why? Why? Because all the androgens are getting peripherally converted into estrogens. Which type of estrogen? E1, estrone. Okay. estrone, estrone, E1. Now, what is this estrogen will do, sir? What is this estrogen will do? Before discussing what this estrogen will do, please see here, I just forgot to mention, not only LH, I have already explained you, LH will stimulate the theca internal cells, helps in the production of androgens. Not only LH will stimulate the theca internal cells, I have explained you, these females, these obese females, what they will have? Insulin resistance is there. Insulin is not functioning in these obese females. Right now, I am giving you a task. In the next 1 month, you become obese. You eat lots and lots of fatty foods, cheese foods. Now, in the next 1 month or in the next 2 months, are you going to get obese or not? You get obese. Now, whenever you get obese, insulin resistance will happen in your body. So, our female is also a obese female. Now, in this obese female, what is happening? Insulin resistance is developed. So, whenever insulin resistance develops, normally, body will produce more and more insulin. Whenever there is insulin resistance, body is thinking there is no insulin and body will try to produce more and more insulin. Now in this female body also, obese female body also, there is more insulin, but it is not useful. It is not actually letting the glucose enter into the tissues. But anyway, our topic is, sir, this high levels of insulin again will stimulate the theca internal cells. Whenever theca internal cells are stimulated by LH as well as insulin, there is more amount of androgens. Androgens are the ones responsible for hirsutism, acne, alopecia. These androgens are converted into estrogens because of peripheral aromatization. So there is higher levels of E1. Higher levels of E1 is there. Is that clear, guys? Whatever I have taught you, is this clear for you? From this, we can understand. Just to close your eyes and tell me. Close your eyes and tell me. Sir, what are the hormones which are elevated in a patient who is having PCOS? Now you will know. Sir, first LH levels are more, sir. There is high levels of LH. Okay. There is high levels of insulin, high levels of LH, high levels of insulin. Now, these females are also having high levels of androgens, hyperandrogenism. Now you know the PCOS females are also having high levels of estrogen, hyperestrogenism is there. Now let's see. Sir, what this estrogen will do? Sir, this estrogen, remember for your entire life, whenever you have enough amount of estrogens will down-regulate the FSH. So FSH levels are going down. Remember, FSH levels are less in any question. If they are mentioning FSH levels are less, but LH levels are more. Normally, FSH and LH, both they are increased. In normal condition, both they will be increased, both they will be decreased. But this here, in this condition, there is high LH, but there is low FSH. Why there is low FSH? Why? Because estrogen is giving negative feedback to the FSH. So FSH levels are going down. Now, whenever FSH levels are going down, do you know what will happen? Sir, whenever there is no FSH, there is no follicular stimulation. Follicle stimulating hormone, FSH. Whenever there is no FSH, there is no follicle stimulation. So follicles in her ovary, what is happening? Follicles are undergoing atrophy. There is follicular atresia is happening. Now, whenever the follicles are not growing, do you think these follicles will ovulate? There is no follicular development at all. Whenever the follicles are not developed, there is no ovulation. So anovulation is happening. Anovulation is happening, no ovulation. So whenever there is no ovulation, now tell me, sir, normally follicles will grow. They will ovulate. Now this is a follicle. This is a matured follicle. Follicle will grow, and it will ovulate and it will release the ovum. It will release the ovum. Let me show you here, guys. This is the follicle. It will rupture and it will release the ovum. This is the ovum. Now what is this? This is ruptured follicle. Now ruptured follicle is called as, I am testing you, your knowledge. The ruptured follicle is called as ruptured mature follicle or the ruptured Graafian follicle. It will become what? Ruptured follicle, it will become what? In a normal female, every month, the follicle will rupture and it will become what? Something called as, it will start with the letter C, guys. Try to answer. I am checking. Guys, a ruptured follicle will become corpus luteum. Normally, whenever a follicle ruptures, it becomes corpus luteum. Corpus luteum normally produce progesterone. So in our condition, there is no ovulation. Whenever there is no ovulation, there is no corpus luteum. If there is no corpus luteum, there is no progesterone. So what happened to progesterone levels in a female who is having PCOS? Whenever you check the progesterone levels are very less. Progesterone levels are less. What about the estrogen levels? Hyperestrogenism, sir. Hyperandrogenism. High levels of LH. High levels of insulin. But decrease FSH, decrease androgens. Sorry, decrease FSH, decrease progesterone. Less amount of FSH, less amount of androgens. Okay, and in the beginning I have explained you. The topic beginning. PCOS is the most common cause of infertility. PCOS females, if a female is having PCOS, she cannot become pregnant. Now you can ask me, why she is not pregnant, sir? Here I am showing you. See, now a female who is suffering with PCOS, she is not ovulating at all. She is not ovulating at all. If she is not ovulating, she cannot be a pregnant. She cannot be a pregnant. Now why she is not ovulating? Why? Because there is no FSH. There is no FSH. Follicles are not developed. If follicles are not developed, there is no ovulation. Whenever there is no ovulation, there is no pregnancy. Infertility will happen. Now, also in the beginning I have explained you in the criteria, in the Rotterdam's criteria, guys. Think about Rotterdam's criteria. There is oligomenorrhea or amenorrhea. She is not menstruating. Like a normal female, every month she is not menstruating. Why she is not menstruating? Because she is not ovulated. If she is not ovulated, normal, see, remember for your entire life, normal ovulatory cycles are regular cycles. If she ovulates, regular cycles will happen. If she is not ovulating, irregular cycles will happen. So she is going to have irregular bleeding. She is not ovulating, so she will suffer with infertility. So why there is infertility? Because there is no ovulation at all. Follicles are not developed. Okay, so in this slide I have explained you the pathophysiology of the PCOS. Why PCOS is happening? Here in this slide I have explained to you. If you have any doubts, please ask me, guys. If you have any doubts, you can ask me. Okay, so from this slide what we have studied? High levels of, what are the hormones which are elevated? The hormones which are elevated are high amount of luteinizing hormone is there, high elevated levels of luteinizing hormone is there, high levels of estrogen is there, high levels of androgens are there. What are the hormones which are less in quantity? Less FSH is there, and less amount of progesterone is there. Okay, now the second MCQ I am asking you, it's the second important question. Sir, in a PCOS female, estrogens are higher in quantity, no doubt. Hyperestrogenism, high levels of estrogen is there. But which type of estrogen? E1, E2 or E3? E1, E2 or E3? E1, sir. E1. Why there is hyperestrogenism? Why? Because androgens are getting converted into estrogens due to peripheral aromatization. High levels of E1 is there. Now, very important MCQ, the second important MCQ, the third important MCQ I am asking you is, sir, high levels of androgens are there, right? Which type of androgens, sir? There are different types of androgens. Testosterone is there. Dihydroepiandrosterone is there. Dihydroepiandrosterone sulfate is there. Okay. Dihydrotestosterone is there. So there are different types of androgens are there. Now, my question is, PCOS females, yes, they do have high levels of androgens. But which type of androgen? See, guys. Now, the androgens which are mainly produced in this female are testosterone, no doubt. Testosterone, the type of androgen which is elevated in this PCOS females are testosterone, main. But apart from testosterone, androstenedione, dihydroepiandrosterone, DHEA, dihydroepiandrosterone sulfate, everything is elevated. But what is the main important androgen which is elevated? The main important androgen which is elevated is testosterone. Now, some important MCQs which you need to know here are, see, sir, there are other diseases where androgens are elevated. There are some other diseases where testosterone levels are going to increase in a female. For example, imagine the female is suffering with a condition called as congenital adrenal hyperplasia. Testosterone level will be elevated in her. There is something called as ovarian cancer, testosterone producing ovarian tumors. Then also testosterone levels will be elevated. Now, in our condition PCOS, testosterone levels are elevated. In the conditions like congenital adrenal hyperplasia, testosterone level is elevated. And in ovarian cancers, some type of ovarian cancers, testosterone level is elevated. Now, how to differentiate, sir, our female? How to differentiate our female from other conditions? Sir, in PCOS, testosterone is elevated, but mildly elevated, not super high, just mildly elevated. all the time the testosterone concentration, if you check, it will be less than 200 nanograms per ml, mildly elevated, not super high. But if a female is having testosterone producing ovarian cancer, she will be having higher levels of testosterone. In congenital adrenal hyperplasia, she is having higher levels of androgens, higher levels of testosterone. But in our condition, PCOS, androgens are elevated, testosterone is elevated, but mildly elevated, not more than 200 milligrams. Okay, sorry, not milligrams, nanograms, not more than 200 nanograms per ml. Is it clear? So keep that one point in mind. Now, what else can be seen in a female who is having PCOS? What else? Like what else laboratory changes can be seen? Sir, PCOS females, are they having high levels of insulin or not? Because of insulin resistance, high levels of insulin is there, no doubt. High levels of androgens are also there because of stimulation of theca interna cells. High LH is stimulating the theca interna cells. Androgen levels are increasing. Now see, this higher insulin levels and the higher androgen levels, do you know what they will do? They will act on liver. Now hyperinsulinemia and hyperandrogenism, what they will do is they will act on the liver and they will cause a decrease in the amount of sex hormone binding globulins, SHBG. So the sex hormone binding globulin levels are going down. SHBG levels are going down. They are sex hormone binding proteins. Sex hormone binding globulins are sex hormone binding proteins. Now these sex hormone binding proteins are not there. Sex hormone binding proteins are not there. Normally, estrogen is bound to sex hormone binding globulin. Testosterone is actually bound to sex hormone binding globulins. Now there are no sex hormone binding globulins. Now what do we have? Sir, estrogen levels are free. Free estrogens are there. Now free estrogens are biologically active. Free androgens are biologically active. Now what I am trying to put into your mind from this slide is, now everyone knows, every student knows from now, estrogen levels are elevated. Estrone levels are elevated in PCOS female, you know it. Androgen levels, especially mainly testosterone levels are elevated. Estrogen levels are elevated. But which estrogens? Are the bound estrogens or unbound estrogens? Unbound are free. Estrogens are freely circulating in the blood. Androgens are freely circulating in the blood. So free hormones are biologically active. They are the ones responsible for the symptoms. Okay, they are the ones responsible for the symptoms. Okay, so this slide also completed. Now here, let's see some important points, guys. Let's see some important points in the polycystic ovarian syndrome. If hirsutism is there, what is hirsutism? It's a male pattern hair growth. Okay, abnormally the hair is growing on the face. Now what is the most common cause of hirsutism? See, most common cause of infertility is what? Most common cause of infertility is PCOS. No ovulation, no fertility. Also remember, the most common cause of hirsutism is again PCOS. The females, see, some females, most of you have seen females with the facial hair. Do you know what is happening in her body? Mostly PCOS is happening in their body. PCOS is that common, very much common. Okay, they will have irregular cycles. Now, apart from that, now if they ask you, the most common cause of hirsutism is PCOS, no doubt. But in the question, if they mention most common cause of rapid onset hirsutism, rapid onset, whenever they use this word rapid onset, in all the exams, whatever the exam is, okay, FMGE, NEET PG or USMLE, whatever, if they are mentioning, there is development of rapid onset hirsutism. Imagine there was this one female who is suffering with PCOS. Normally, she has features of hirsutism gradually. Hirsutism is not going to happen just like in 1 month. Gradually, it's a slow, benign feature. But imagine there was this one female with a ovarian cancer, and this cancer is producing, okay, there was this one female with ovarian cancer which is producing excessive amount of testosterone. Now, this cancer is pouring testosterone like hell. Lots and lots of testosterone is coming. Now, whenever she is having this testosterone producing tumor, now this excessive amount of testosterone will cause rapid onset hirsutism. So, if they mention the word rapid onset hirsutism, think about androgen producing tumor or testosterone producing tumor. Or else, if they simply ask you, what is the most common cause of hirsutism? So, the most common cause of hirsutism is simple PCOS. Done. Now, I have explained you. There is this one disease called as congenital adrenal hyperplasia, CAH, congenital adrenal hyperplasia. There also testosterone levels will be elevated. In congenital adrenal hyperplasia also testosterone levels will be elevated. But how to rule out, sir? How to rule out congenital adrenal hyperplasia? Sir, in congenital adrenal hyperplasia, the most important marker is 17-hydroxyprogesterone levels. Normally, 17-hydroxyprogesterone levels are elevated in congenital adrenal hyperplasia. See, try to understand like this. PCOS female have high levels of androgens, true. Congenital adrenal hyperplasia females have high levels of androgens. But how to differentiate a female with a congenital adrenal hyperplasia along with androgens? She will have high levels of 17-hydroxyprogesterone. And the androgen levels are also super high. Okay, the androgen levels are also super high. But in PCOS, androgens are elevated, but mildly elevated, less than 200 nanograms per ml. Okay, so this is how we will rule out congenital adrenal hyperplasia, female with high levels of 17-hydroxyprogesterone as well as androgens. Now, direct questions, guys. Some important direct questions which are asked which are tested in the exam. What is the scoring system? Scoring system for hirsutism. Sir, Rotterdam criteria is the diagnostic criteria for PCOS. The name is Rotterdam's criteria, diagnostic criteria for PCOS. Right now, what I am talking to you, what is the scoring system? How severe the hirsutism is, the scoring system. The scoring system is called as Ferryman-Galway scoring. Question which was asked a lot of times in the exam. Ferryman-Galway scoring is a scoring system. A score greater than 8 is indicative that, okay, she is having hirsutism, diagnosis done. Okay. So, these are some important points which you need to keep in mind. Now, after this, let's talk about what these estrogens will do. There is lots and lots of estrogens are there or not. A PCOS female, sir, in her body, because of peripheral aromatization, androgens are converting into estrogens. Now, what these estrogens will do? Very important, guys. Estrogens are the food for endometrium. Even in the topic of endometriosis also I explained to you. Estrogen is like a food to endometrium. So she is having so much amount of estrogen. Now this so much amount of estrogen will stimulate the endometrium. It is stimulating the endometrium. So there is endometrial proliferation. Unnecessarily, abnormally, endometrium is proliferating. Now this endometrium, it's proliferating and causes endometrial hyperplasia. This endometrium is constantly stimulated. The constant stimulation, too much stimulation is all the time bad. So the endometrial hyperplasia can anytime convert into endometrial cancer. Okay, too much stimulation is all the time bad. So this excessive amount of estrogens will cause endometrial hyperplasia, and that endometrial hyperplasia can turn into endometrial cancer. So now tell me, guys, these PCOS females, are they at a risk of developing endometrial cancer or not? Endometrial cancer or uterine cancer, they are one and the same. So PCOS females, they are at a risk of endometrial cancer, true. Now, because of this excessive amount of estrogen is also going to act on the breast. So there can be breast cancer, there is a possibility of breast cancer. So PCOS females are at a risk of breast cancer. Even this estrogen can act on ovaries. So too much amount of estrogens, too much action on ovaries, so that can lead to ovarian cancers. So what I am trying to put into your mind is, guys, these females with hyperestrogenic states, they are at a risk of uterine cancer or endometrial cancer. They are at a risk of breast cancer, and they are also at a risk of ovarian cancer, true. Okay, so these are the cancers. These are the cancers. These are the females who are at a risk of developing these cancers. Okay. Now, after discussing this, now what else you should know regarding PCOS? There is this one particular laboratory abnormality which is seen. Sir, high levels of estrogen is there in the female body. We know. Now, these high levels of estrogens, previously already we have discussed, they are going to give the negative feedback to FSH. So FSH levels are low, but LH levels, we don't know the reason why LH levels are elevated. I have already told you. Sir, FSH levels are low. In the beginning of the topic, please try to recollect. We have started the topic with the high levels of LH. Now I will tell you why high levels of LH is there. Remember, guys, estrogens, they will negatively regulate the FSH, no doubt. But the same estrogens, physiologically also, same estrogens, they have positive stimulation for LH. So our females are having high amounts of estrogen. This estrogen will down regulate the FSH but up regulate the LH. So what happened to FSH to LH ratio, or what happened to LH FSH ratio? Now if they ask you in your exam, see, right now I am showing you LH to FSH ratio. So LH levels are elevated, so LH is more and FSH is less. So LH to FSH ratios in a female who is suffering with PCOS is 2:1, reversed. Normally it should be 1:2. Normally it should be 1:2, but here it is reversed. LH to FSH ratio is reversed. It became 2:1 instead of 1:2. Okay, this is something which you can appreciate in PCOS female. Now what is the treatment? We are ending, guys. We are coming to the end part. Now what we can do? How to treat this PCOS? Now first, the major problem with these females is their diet. They are obese. Their lifestyle. Okay, their lifestyle. Now what we have to do is first ask her to reduce her weight. Now whenever she is coming back to his normal BMI, okay, whenever she is coming back to her normal BMI, most of her problems will be treated. Again she will start her menses, her insulin resistance will come back, okay, she will have her normal periods, hirsutism will go back. So first thing what you can do is ask her to undergo weight loss. Why? How this is helpful? See, I will explain you. Whenever she is reducing her weight, what happened to the amount of adipose tissue in her body? Sir, her fat is coming down. Her fat is getting down. Now, fat is the place where, adipose tissue is the place where peripheral aromatization is happening. What is peripheral aromatization, sir? Conversion of androgen into estrogen. Conversion of androgen into estrogen. Peripheral aromatization. Where it will happen? It will happen in adipose tissue. It will happen in adipose tissue. So whenever she is losing her weight, whenever there is weight loss, adipose tissue is going to decrease. So whenever adipose tissue decreases, what happened to peripheral aromatization? Right. Okay. What happened to whenever she is losing weight, adipose tissue decreases, peripheral aromatization decreases. So whenever peripheral aromatization is decreasing, amount of estrogens in our body also goes down. Whenever estrogen levels goes down, that is something good. That is something good. These females are hyperestrogenic. Now we are trying to decrease her estrogen levels. Okay. Now let's continue, guys. We are also going to give these females a drug called as metformin. Now why we are giving this drug called as metformin to this female? Metformin, sir. Metformin decreases the insulin resistance. Very, very important. See, metformin drug. Metformin. What kind of drug is metformin? Is it a sulfonylurea? No. What kind of drug is metformin? Anti-diabetic. Anti-diabetic. Biguanide. Biguanide. In pharmacology you would have studied. Okay, you have studied, I think so. So, metformin is going to decrease insulin resistance. Our females are suffering with insulin resistance. So, we are giving drugs like metformin to treat insulin resistance. Now, after metformin, what else we can use? We can use progesterone. We can use progesterone in this female. Now, why we are giving progesterone? Why we are giving progesterone? The main culprit is who? Sir, the main culprit in PCOS is luteinizing hormone. The main culprit. Now, what we can do? We have to decrease the amount of luteinizing hormone. If you decrease the luteinizing hormone, everything is going to come back to normal. So, normally, physiologically, see, know this one point. Normally, estrogens will down-regulate FSH. Estrogens will negatively regulate FSH. Luteinizing hormone negatively regulate LH. Okay. Progesterone. Progesterone will give negative feedback to LH. Estrogens, sir, decrease FSH levels. Progesterones decrease the LH. So what I am doing in PCOS females, high levels of LH is there. So how I can decrease the high levels of LH? I will give drugs which are progesteronic in nature. So by giving progesterones, LH levels are going to come down. If LH levels comes down, everything is set. Everything is going to be treated. Now, after progesterone, what else I can do? Sir, these females, PCOS females are suffering with a problem called as infertility. Now she is suffering with infertility. Now how to treat her infertility? By giving ovulation inducing drugs like clomiphene citrate. Sir, when I give clomiphene citrate, again she will start to have ovulation. She will start to ovulate. Super ovulation will occur. So drugs like clomiphene citrate and letrozole. Guys, remember, this was a new update. Previously, the drug of choice, for ovulation induction is clomiphene citrate. Previously, if a female is not getting pregnant, we use drugs like clomiphene citrate, but now recent update, letrozole is the drug of choice. Okay, letrozole is the drug of choice. Whenever you give letrozole, she will now ovulate. Now, whenever she ovulates, she will become pregnant. She will become pregnant. PCOS, no ovulation. But whenever you use the drugs like letrozole and clomiphene citrate, she will ovulate, sir. She will become pregnant. Okay. Now, let's talk about hirsutism. These females are also having a problem of hirsutism. So, how to treat hirsutism? Abnormal hair. How to treat hirsutism? Simple. Drugs like OCPs, oral contraceptive pills. Now, see here, oral contraceptive pills. Now, you will get it out. Sir, what are these oral contraceptive pills? Oral contraceptive pills are nothing but estrogen and progesterone combination. Oral contraceptive pills. What is there in oral contraceptive pills? Estrogen and progesterone is there. Estrogen and progesterone is there. Now, this progesterone, what it will do? I have explained to you. Sir, progesterone, it will decreases the LH. Progesterone all the time decreases the LH. So, whenever there is no LH, there are no androgens. Normally, LH will stimulate. Please think, please recollect. LH acts on theca interna cells. Whenever LH is acting on theca interna cells are producing androgens. Now, what we are doing? Sir, you are giving oral contraceptive pills with progesterone in it. Progesterone is going to inhibit LH. So, whenever there is no LH, there is no androgen. Whenever there is no androgen, automatically you have treated hirsutism. So, what is the drug of choice for hirsutism? So, the drug of choice for hirsutism are oral contraceptive pills. Oral contraceptive pills. Apart from oral contraceptive pills, there are other drugs which will treat the hirsutism like spironolactone. Spironolactone. What is this spironolactone, guys? Spironolactone, anti-androgen. Spironolactone is anti-androgen. Anti-androgen. So, androgen levels are going down. Hirsutism is treated. Hirsutism is treated. And cyproterone acetate, anti-androgen. Decrease androgens, hirsutism is treated. Okay. So, these are the drugs which we can use for the treatment of PCOS. Now, last problem. Usually, whenever the female is having PCOS, imagine there is this one female who is 25 years old or 20 years old. Now, she is suffering with oligomenorrhea. Now, she is not having menses regularly. No periodic menses. No periodic menses. She is menstruating once in every 2 months or once in every 3 months. Now, what I have to do? I have to regularize her menses. I have to bring her menses like, every month. Now, what I am going to do, I am going to use drugs like again OCPs. Now, why I am using OCPs, sir? What exactly are OCPs, guys? Estrogen plus progesterone. Now, I am giving her every month. See, I am giving her estrogen and I am giving her progesterone. So, if I am giving estrogen and if I am giving progesterone, what happened to the endogenous estrogen and progesterone levels? Now, I am supplying estrogen and progesterone from outside. Sir, when I am giving estrogen and progesterone, her endogenous progesterone levels goes down, her estrogen levels goes down. Endogenously, whatever she is producing, estrogen levels goes down in her body, progesterone levels goes down in her body. Endogenously, I am giving estrogen, I am giving progesterone. So, I am regulating her hormonal control from outside. I am regulating estrogen concentration, I am regulating progesterone concentration. So, what happens? First, initially, I am giving estrogen. See, try to understand. Initially, I am giving estrogens to her every day. So, her endometrium is going to grow. First 14 days, endometrium is growing. Later, I am giving progesterone. So, progesterone is stabilizing the endometrium. Okay, everything is good, sir. Now, what I will do? 21 days I will give oral contraceptive pills. Okay, OCPs. I am going to give 21 days. I am giving estrogen, progesterone. So, everything is good. Now, the last 7 days, I am going to stop. Last 7 days, I am not giving any hormones. I am not giving estrogen. I am not giving progesterone. So, what will happen? I am actually taking out the hormones from her body. I am taking out the hormones from her body. I am not giving progesterone. So, whenever I am not giving progesterone, there is no progesterone in her body. So, immediately menses will come back. Menstruation will happen. All that endometrium, whatever has grown, it is now shedding and coming out in the form of menses. So what I'm doing, by giving hormones from outside, I'm regulating her hormone levels inside the body. I'm bringing back the menses. The main problem with the PCOS is hormonal irregularity. The main problem with PCOS is hormonal irregularity. But what I'm doing, by giving oral contraceptive pills in a proper doses, I'm maintaining her hormone levels. So again, menses come back. So this is how you will treat oligomenorrhea or amenorrhea. So oligomenorrhea, amenorrhea is treated. Hirsutism is treated. Her infertility is treated. So infertility is treated with ovulation inducing drugs like letrozole and clomiphene citrate. Hirsutism is treated with OCPs, as well as her amenorrhea or the oligomenorrhea is again treated with oral contraceptive pills. So regularly giving estrogen, progesterone for 21 days. Suddenly if you stop these oral contraceptive pills, now she will start to menstruate. I have get back her menses to normal. So with this, the treatment of polycystic ovarian syndrome is also completed. Okay guys, we have done the two important topics. Hope the video is helpful. See you tomorrow with the next important topic of uterine prolapse. Tomorrow at the same time, let's meet and discuss about uterine prolapse. Hope the video is helpful. Thank you.